You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 21st, 2022. This week, olive oil, breastfeeding and cardiovascular health, informed consent during acute stroke, and controversy regarding the revascularization guidelines. First up is olive oil. Now, the top cardiology journal has published a study on olive oil. It's the most read news story on theheart.org, Medscape Cardiology. It's been covered by more than 100 news outlets and has been tweeted more than 200 times. But before I tell you about it, I want to give a disclosure. I'm half Italian and was raised in an Italian-dominated family, but I don't really like olives. Okay, now to the study. A research team led by the Harvard Chan School of Public Health used a nurses' health study and health professions longitudinal databases to evaluate the association of olive oil intake and total and cause-specific death rates. You know the format of these studies are familiar. A, they assess olive oil intake with food questionnaires. B, they break down olive oil intake into 4 categories: none, a little more, and a lot. C, they assess death rates. D, they calculate hazard ratios based on olive oil consumption. And then E, they make statistical adjustments. Now, since this is the lead article in JACC and since it's received so much attention, you can probably guess the results. The multivariable adjusted pooled hazard ratio for all-cause mortality among those who had the highest consumption of olive oil was 0.81. So that's a 19% reduction. It was statistically significant. And it gets better for olives. Higher olive oil intake was also associated with a 19% lower risk of cardiovascular disease mortality, 17% lower risk of cancer mortality, 29% lower risk of neurodegenerative disease, and a 18% lower risk of respiratory disease. In other words, olive oil just shreds all human diseases and proves to be a modern-day fountain of youth. Now, before we talk about the elephant in the room, which is bias, let's first point out that olive oil has a number of potential healthy attributes. It has anti-inflammatory, anti-atherogenic properties. It may improve lipid profiles, reduce blood pressure, lessen endothelial dysfunction. I have no doubt olives are better for us than Fritos. But, my friends, if you believe that a self-reported delta of just 0.5 tablespoons per day of olive oil leads to this degree of death, cancer, and dementia reduction, I have a left atrial appendage plug to tell you about. Now, please do read the editorial from Dr. Susanna Larsson from Uppsala, Sweden. She gently points out the problem of residual confounding. That is, people who self-report olive oil intake are healthier than those who don't. Now, to me, the fact that 3 of the most common causes of human death and disability were crushed by olive oil strongly suggests correlation, not causation. Now, you also have the issue of self-reporting dietary intake. This was done every 2 years. I mean, if I was asked what my olive oil or canola oil or butter intake was over the last 2 years, it would be a total guess. I mean, I could tell you my pizza intake, but not much else, because our family eats pizza on Friday night. Now, I also realize there may be a stray expert in statistics who happens onto this podcast. Now, the authors use complicated stats to try to adjust for confounding, and the stats are probably top-notch. But you can only adjust for the data you have on the questionnaires and the spreadsheets, which I think is barely the tip of the iceberg when you think of all the causal factors that go into getting heart disease, dementia, or cancer over 2 decades. In sum, by all means, if you like olive oil, use it. But I don't think I would say you should eat it to lessen human disease. To me, the benefit of the Mediterranean diet stems mostly from the fact that people who adhere to it eat a lot less processed things like pop chips. Next topic is breastfeeding and cardiovascular risk. Now, speaking of observational studies at risk of confounding, the Journal of the American Heart Association published a meta-analysis of 8 studies in over 1 million women looking at the association of breastfeeding and future cardiovascular outcomes of the mom. Now, the moms who breastfed is one group, the moms that did not is the other group. Now, the main findings were that when authors combined the 8 studies, breastfeeding was associated with an 11% lower risk of maternal cardiovascular disease. Hazard ratio was 0.89, and the confidence intervals were statistically significant. The risk reduction from breastfeeding was 14% for coronary artery disease, 12% for stroke, and both those were statistically significant. Okay, here we go again. If you take these at face value, you can use this paper to promote breastfeeding. You could say there's biologic plausibility for maternal benefits for the mom, and boom, we have major statistically significant reduction in a study with 1 million subjects. But there are 2 major parts of interpreting a meta-analysis that this study highlights as learning opportunities. One is that when you do a meta-analysis, you apply something called the GRADE level of quality evidence. It's grading of recommendation, assessment, development, and evaluation. And there's a tool to assess the quality of the evidence of the included studies. And part of a meta-analysis is understanding the quality of the studies that you're combining. The authors did this, and they report that the included studies range from very low to moderate quality of evidence. Well, that makes perfect sense, right? Because observational studies comparing women who breastfed to those who did not are going to be at risk of bias because women who breastfeed almost certainly differ in many ways from those that did not. Of course, the authors tried to make statistical adjustments, but as I said earlier, adjustment can only be done for the covariates that are on the spreadsheet. There is another important part of interpreting meta-analysis that we can see in the study, and that is something called heterogeneity, which is an awful jargon word, but basically the idea is that when you combine studies, your confidence in the results turns a lot on how similar they are. In this study, the heterogeneity of the combined studies was off the chart. We measure it with something called the I-squared statistic, and you want it to be low. In this study, the I-squared was nearly 80%, meaning that the authors were combining studies with results that were all over the map. Now, I'll link to a nice review from Italian authors on the pitfalls of meta-analysis, and you can see the show notes for that. Here is a quote from their paper. When high heterogeneity is evident, individual data should not be pooled and definitive conclusions should be drawn when more studies become available. Final comment. I am no expert on breastfeeding, and I know there are many great reasons for moms to breastfeed, and one of them may be better maternal cardiovascular health. But this data cannot and should not be used to promote that benefit. I think the biggest benefit of this data is in highlighting the limits of observational data and in showing some of the pitfalls of meta-analyses. The next topic is informed consent. The journal Neurology has published new guidance on informed consent in acute stroke. Journalist Sue Hughes has excellent coverage. The issue is important because patients who present with stroke may, by virtue of the brain ischemia, not have decisional capabilities. And of course, there is a need to work quickly with acute stroke. The problem here is that acute stroke therapy remains controversial, in my opinion. In Sue's news article, there is this quote, he gives a classic example of standard of care as a patient presenting with an acute ischemic stroke within 3 hours of symptoms who meets the criteria for thrombolysis. Quote, even if they cannot speak and cannot consent, that would be a classic example to proceed with thrombolysis as the indication is clear-cut. But I would strongly disagree with this statement on the grounds that a critical appraisal of the systemic lysis literature suggests that classic and clear-cut are hardly the right modifiers for indication. Now, way back in 2018, I wrote a column making the case against IV thrombolysis and acute stroke, and I'll link to it and I hope you look at it. While many in the emergency medicine community agreed, and in fact, the emergency medicine community has really led the way in critical appraisal of this area, the neurology community strongly disagreed, and I will link to their rebuttal, and I urge you to read both, as a neutral Martian would. The issues are complex and beyond the scope of this podcast, but include that 1, the original NINS trial had baseline differences in stroke severity, and a subsequent patient-level analysis suggested that the small benefit seen with TPA in that trial was likely due to baseline stroke severity, not the drug. Second issue, there were many IV TPA trials and most were null. Only 2 were positive. The benefit, if there is one, is measured in a very subjective scale called the modified Rankin scale, which is not always reproducible. IV TPA clearly increases the risk of intracranial hemorrhage, and IV lysis leads to an early mortality signal. Now, before you all get mad at me, I've backed off a bit from my 2018 stance, but at best, you can say that absolute risk reduction in a subjective improvement with thrombolysis is small, and the upfront harm of ICH and early death is real. At worst, a commonly accepted therapy is of no net benefit. The take-home for me is that informed consent here is going to be super hard if you look at the data closely. I guess you could say that about a lot of different therapies. And a final caveat, the RCT level data for endovascular therapy for acute stroke when patients are eligible is more robust than for IV lytics. Here I think the informed consent process will be a little easier. Now this post makes the podcast because IV lytic therapy is one of the most intriguing areas of critical appraisal that I know of, and because informed consent is so darn important to medical therapy. The final topic today is controversy in the coronary revascularization guidelines. In December, the ACC, AHA, and SCAI published a new guideline for coronary revascularization. The guideline sparked serious controversy among surgical societies. First, the American Association for Thoracic Surgery and the Society of Thoracic Surgeons withdrew their support. More recently, the Latin American Association of Cardiac and Endovascular Surgery has demanded urgent reconsideration. Now, the points of contention. First, the guideline authors downgraded the recommendation for coronary bypass surgery, CABG, in patients with multivessel disease to reduce overall mortality from a Class 1, the highest level, to 2B, the lowest level. The surgical groups also found problematic the fact that both CABG and PCI garner the same 2B rating for patients with multivessel disease. The 4 surgical arguments are instructive. First, surgeons point to the famous Youssef et al. Meta-analysis of CABG versus medical therapy from 1994. This was published in The Lancet. This established surgery as superior to medical therapy in patients with multivessel disease. Surgeons also cite Syntax, XL, Noble, FAME3, which all point to the notion that CABG is superior to PCI for major cardiovascular outcomes. Now, the third surgical argument against downgrade stems from the 10-year follow-up of the MASS-2 RCT, which compared PCI, medical therapy, and CABG, and found a lower incidence of cardiac mortality as part of its secondary outcomes after CABG compared to optimal medical therapy and PCI. Finally, the surgeons argue against the use of the ischemia trial to downgrade CABG. Now recall that the ischemia trial studied early invasive to delayed invasive angiography and revascularization in patients with stable but serious inducible ischemia. The ischemia trial found no reduction in cardiovascular outcomes for the invasive early approach. Now, I think this fourth point is most important. What the guideline authors, I think, are saying is that, look, ischemia included patients with serious coronary disease and revascularization, which included CABG, and it had no effect on heart outcomes, so we should downgrade the indication to do CABG in patients with stable CAD and multivessel disease. Now, part of me agrees with them. The part that feels that stable coronary disease is really a stable condition. I mean, Bill Bowden, the PI of Courage, frequently reminds me that docs think patients with multivessel disease are going to fall over dead if not fixed immediately. But recall that in the ischemia trial, there were only 66 sudden deaths among nearly 5,200 patients. The incidence was only 1.3%. Now, by the way, Bowden and co-authors, including the PI of Orbita, Rasha Al-Lami, have a great editorial on optimal medical therapy just published in The Lancet, and I'll link to it. The other part of me that agrees with the guideline authors is that medical therapy is pretty darn good these days. Sure, the Youssef et al. Meta-analysis found that CABG beat medical therapy in 1994, but medical therapy is a heck of a lot better these days. Now, I know surgery is also better, but finally, I lean towards agreeing most with the surgeons here. because it is simply not correct to cite the ischemia trial as a reason to downgrade CABG to the lowest recommendation based on early revascularization not improving outcomes in that trial. The reason, of course, is that only 24% of patients in ischemia receive CABG while 76% receive PCI. So it seems like a huge leap of faith to think that the small subgroup of ischemia patients who had CABG means that surgery should be relegated to the lowest level of the recommendation. And as far as I know, there are no publications looking at the surgery subgroup, but perhaps there shouldn't be because the statistical power of a group of only 24% of patients who had CABG would seem pretty low. And of course, patients who are referred for surgery are going to be inherently sicker and they'll be biased there. So in sum, I mostly agree with the surgical pushback. It seems more reasonable to put surgery at a higher level than PCI. But here's the final thing. I really wonder how much effect these guidelines will have in the US. And I say that because here, practice patterns are so entrenched. Now, maybe in Europe, guidelines have more of an effect on practice, but again, in the US, I'm not sure. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, it really helps to give us a rating, write us a brief review, make a comment in the comments section on the heart.org Medscape Cardiology. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.